Hi, everyone. This is John Hansbrough with the LBL Group. We're here to talk to Levi Remmick. He's an old college buddy of mine, and he's working for Cope Health Solutions. He's a healthcare consultant there. And so, our work at the LBL Group, we're really focused on employers and that as the payer focus that we have on who we're consulting with. Levi and his team, they focus on consulting with the actual delivery systems themselves, right? So the actual healthcare organizations and providers, health systems who have you. And so, it's kind of like we're talking about similar concepts to slightly different audiences. And so we thought it would be really fun to come together, talk a little bit about some of the stuff that we're seeing in healthcare. One of the things, just quite honestly, Levi, we're both two guys in our 30s. A lot of the times we're hearing a lot of, people later in their career with a lot more experience talking about these things. I think it's fun that we are, younger generation coming up. We maybe have a little bit of a different perspective, and we're getting excited about some different things going on in the industry. End of the week, it's 5:30. How are you doing?
I'm doing pretty good. Wrapped up a few projects this week, feeling good about it. And just while you brought that up, being the age that we are in this particular industry, I think this is a theme that we'll see kind of across most of the things we talk about is everyone's just been doing things the way that they've been done because that's the way that they've been done. And there are a lot of ideas out there. And I think one of the biggest struggle, not really struggles, but challenges with kind of the new wave is the buy-in and just having enough of people taking those chances, right? Because a lot of the executives and all the people running the show, they're just kind of more or less waiting for retirement. They don't want to rock the boat too much because they're about to cash out and they've got a board they're reporting to and all of those things. And so being the new wave, it is important that we do try new things because obviously what we have right now isn't working the way it was intended, or maybe it is, and that's horrific to think about. But just wanted to touch on that before we get into anything else because I think it applies across the board.
Totally. Well, and with an industry that, I think if you kind of draw this line back to, you could probably go to the 80s or 70s, but really, employer-sponsored healthcare started during and after World War II, right? There was a freeze on the ability to increase salaries to people. And so as a compromise, the government said, well, companies have already sometimes been paying for their employees' health insurance. We're going to make that a tax-deductible form of compensation. And so because that fell outside of salaries, companies then said, wow, okay, we're going to start now paying for our employees' health care. And then that just evolved from there, right? I mean, it's one of those just butterfly effect things. It's just now mushroomed into, from our side, what we're seeing and how it's affecting employers and how they're paying for healthcare and all the decisions that are getting made in the delivery of care and how so much of it comes back to the economics of healthcare. It created a crazy just butterfly effect, right? And so I agree with you there. It's like we're trying to change the direction of this gigantic cruise liner. And so it's not going to happen overnight. And so I think if, someone maybe is 5 or 10 years away from retirement, there's so much work to try to get this thing back onto the right course. That's a lot of work for them to do without the ability to see, the returns from it over time, right? Whereas for us, we're seeing these things. We have grown up now through 2 financial recessions, which is crazy for us to think about, right? We go through 9/11 and the slight recession after that, we go through the '08 financial crisis, and now we're in a new one. And so we've seen all this disruption in a lot of ways how the status quo hasn't been working. And so, I think that's like a great spot to start. What else is exciting for you about healthcare? Like, why do you think this is a space where more people should be trying to jump into right now?
I guess when it comes to, like, you think about, and this is, a little bit cliche, but, whatever, it's true, like making an impact on the world, right? Like doing something that's impactful, that'll affect generations of people in a positive way. And it's just one of those things where it's just so broken currently. Like there's only for all of the reasons. And I don't know, it's an opportunity to make a change and make a lasting change that really matters to people and affects people's lives. Like, I think that's number one. And then number two, I think just from the way that my brain works in particular, I've always been a big fan of things you can't necessarily win. Like you just constantly improve, but there's no like, okay, I did it. I fixed healthcare, right? There's like always ways to grow and learn. And so I think that aspect of it is also very appealing.
Right. There's no finish line that we're going to cross and confetti's going to rain down from the ceiling and say, oh, we're done. We fixed it.
Right.
But I think there's so much space for us to do, right? I mean, we spend way more than any other developed country. And then we rank, depending on the measurement, the most recent one I saw was that we ranked 37th in the world in terms of health outcomes. So we're paying more than everyone. And we're not nearly getting as much value as other countries are. So
Right.
there's a big gap for us to close.
And then,
But I think that, like,
I
think is what I was going to say is, like, the younger generations, right? You're seeing this interesting disconnect where older generations much more were craving that financial security. So they were seeking the security coming from a high salary and reliable income and all those kinds of things. The younger generations, though, they want to see more impact on the world, right? And I know that's the case. Like, I think that you're seeing that sometimes in how different generations are getting recruited and pitched to. They're trying to talk more about mission and purpose and all those kinds of things. And, everyone is going to come into contact with the healthcare industry multiple times over the course of their life. That's going to touch everybody, right? And so the ability to impact, every single person in the country by working on these kinds of things is like too good of an opportunity to pass up.
Absolutely.
Yeah. So, one of the things that you guys are working on is population health management, value-based payments. Like, there's a lot of different areas where you're consulting with providers and health systems. What are, I guess, like, starting from a why, right? What are the issues out there right now that COPE is dealing with and you guys are seeing that you're starting at trying to address before you actually get into any strategies or solutions? What are the big problems out there that you're encountering with health systems?
Yeah. So the first, and it's not necessarily health systems, but I think it's the mindset behind healthcare in the US currently, is it's more so, and this is more so sick care than it is healthcare, right? Like, it's, oh,
Right.
This is broken, come in and let me bandage it up and I'll see you later, rather than being involved in their lives and actually, not just keeping you healthy enough to where you're not sick, but like actually improving the quality of your life, like taking you where you are now and making sure that you're living at a high level of, well-being and happiness and all those things, not just when you need it, right? So the average American, I can't think of the last time I've had my own personal, like, annual checkup, right? It's been like a few years now, which is bad on my part, but that's just like a prime example of like the culture that we have here, right? It's like, oh, you only go in when you're broken, not like, oh, I should probably go in, every so often, every quarter, every, twice a year, things like that, to really make sure that, you're in tip-top shape. So I think
But that can
is
happen,
just
though. I mean, that's like there's such a lack of primary care physicians in the country already, and that gap is just widening. we don't do
absolutely.
preventative care.
Right. And not even primary care physicians, like even going lower and just, nutrition education and things like that. Like, the information isn't being taught, isn't being spread. So like, yeah, while primary care physicians is definitely a place that we, need to be more involved, but even just the communities in general need to, it's less of like a clinical setting and more of just a cultural change, right? Because most of, all of our, the things like diabetes and high blood pressure and heart disease and all of this, like, all very avoidable. I mean, some, obviously there's situations where things happen and, people are genetically predisposed to certain things. Of course, I'm not discounting that as a reality, but in general, the amount of education and the amount that we actually talk about these things and really have it assimilate throughout the culture is something that we neglect, I think, as a country.
Totally. And so, right, there's like, I guess, there's not competing forces, but there's forces coming from different angles here on that. Just the lack of preventative care and the lack of people getting preventative care can be drawn from two different things, right? You're saying from the consumers not seeking it out. And there's a culture around not treating for things. But on the other hand, we also are seeing a lack of primary care physicians, a lack of those providers. And so there's like a ton of different conversations just to have right there. One thing I was reading is that if you look at these statistics on like student loan debt for medical graduates, it's astronomical, right? It's something like the average medical graduate has about $200,000 in debt when they graduate medical school. And then 25% of them have debt over $300,000. And so if you're looking at that and you're saying, well, I know that a general practitioner is going to make, X thousands of dollars a year, but if I specialize, I can make, 100%, 200% more than that. You're going to make an economic decision there. And so there are some interesting conversations around what kind of incentives you can have on trying to incentivize graduates to go into, primary care and be available for those kind of preventative screenings. That's a huge issue, right? And we see that with like
absolutely.
Yeah.
It's and people are following the money, and that's the whole thing around this value-based system is our financial incentives are setting people up for these, you made the point, economical decision, right? Like, okay, I might as well specialize and get X amount a year. And then again, that's where a lot of this pushback from, you know, this change in the system to go value-based happens, is now you have all of these specialists, and where are they going to work, right? Because if you're working in if you're in a system of population health management there, like, you're only going to require a certain number of specialists, because in this system, it's just diseases aren't getting to the point where you're needing all of this specialized care, or, you know, so it's more so, and it's tough because it's got our generation is more mission based, because it is like the social workers and things like that we do need more of, and that really a lot of this new healthcare is going to be more based around things like care navigators, right? Like people making sure that, you know, they're going to their appointments and refilling their medications if necessary, and things like that. Like people actually in the community making sure that people are on top of the things that they are on top, that they need to be on top of in their own health. And also just where to start, where to go, right? Most people, I mean, we talk about the education of the system, just like, oh, I need to go to the hospital. Like, this is happening, I need to go there, right? And now that hospital bill is going to be far greater than had you gone to, say, an urgent care, where maybe someone didn't know urgent care was an option, right? And it's just little things like that, that it's the preventative and also the education of like how to navigate our system, because the default is the most expensive, and that's kind of how it's set up, because everyone gets paid that way.
Right. It's one, if you wait for issues to be bad, you're going to then pay top dollar to get them treated, right? And we see that when we talk to employer groups, specifically employees, right? We're going to do open enrollments, we're talking to these employee groups, and we're saying, pay attention to whether you have something that really requires an ER visit, or if it could potentially be dealt with in an urgent care environment, right? And so one solution there is actually plan design, right? So again, you're talking about incentives. You're saying to employees, you're going to pay more to go to the ER. So you need to make sure that it's the appropriate visit for that, because statistically, you look at that so many times when people go see the ER or go see specialists, those are visits that are not life-threatening. And a lot of times, they're actually visits that can be taken care of by seeing a general practitioner, or in some states, a nurse practitioner, right? There's other ways of accessing that care at the lowest dollar possible. And then there's a ton of tangents off of that. But I think before we dive into some more of that stuff, I think if we level set would be helpful. Can you give us like a really brief overview, a little foundation here over what fee for service versus value-based payment models, and there's different jargon around that. What does value-based versus fee for service mean at like a base level?
Yeah, so fee for service is pretty standard. You'll have a DRG code or a code for a procedure that is worth X amount of dollars, depending on, you know, all the different codes that would go into it. And so there's no real arguments or anything. It's all set up at the beginning of the year, what every procedure is going to be worth. And then when you perform said procedure, you get paid those dollars. So a fairly straightforward fee for service. Whereas value-based payment allows the health plan to create their own mechanisms of payment. And you can do it a variety of ways, because obviously not all environments are the same, right? You could be a rural area, or you could be a very populated area, and some things might not make sense to you know, it could be out of your control. So you can more finely tune it to exactly the needs of your providers and your population, but you would be paying based on performance, right? So if I go in for a triple bypass in a fee for service, you just get paid X amount of dollars. Whereas like a value-based payment, there may be some criteria in that agreement that says, well, if they get hospitalized again in the next, you know, 2 weeks to 6, you know, whatever the time period you say, then like, no, you're not getting full payment on that. So like you did not complete your job with high quality. And so you can implement these quality measures. And a lot of times the ones that we do, they're fairly simple. It's things like calling, follow-up call, you know, 7 days after a procedure, things like that. Like nothing too crazy. It's very simple, just being in touch with your population. Or it could also be things as simple as like having a plan for follow-up, you know, just having certain specific clauses in the payment plan agreement. And again, it can be customized to anything you really want, but it's focused on the outcomes rather than just the procedure itself. And it just
Gotcha.
And in a great environment, if you're a great provider, you're all for this, right? If you do a great job, like you'll end up making more money. But it's, you know, it's seismic shift in the way people think, and just some people are not used to. It's a tough sell in a lot of different environments for various reasons.
It totally is, yeah. I mean, the thing with fee for service that we're always kind of seeing, right, is that there's not, the lack of payment based on outcome means that there's a financial incentive to more, right? There's always going to be a financial incentive to adding more into a bill. And when consumers, like in most kinds of insurance plans, the insured only knows so much about what they're paying. So they don't really know the like 90% that's getting paid by their employer, right? Or if they're on like say Medicare or Medicaid or some other kind of insurance plan, let's say they need a knee surgery, right? And musculoskeletal outpatient procedures like that, knee surgeries, back surgeries, et cetera, they're a huge component of a lot of medical spending and a lot of waste in spending. And so if you have to go get a knee surgery done, you don't really know how much hospital A versus hospital B charges for them, right? You could be paying $40,000, and I'm saying you here with quotation marks, right? It could be $40,000 to get it done at hospital A, and it could be $20,000 to get it done at hospital B. Meanwhile, Medicare is going to pay even a fraction of that $20,000. But consumers don't know that, because if they're all in network, they're paying the same amount to go to whichever hospital. And they don't have outcome measurements, so they don't even know which hospital is better at it than the other one. They're usually working off of word of mouth or just wherever their longtime physician has been contracted with. So for the value-based payments, have you guys been seeing like a trend towards more hospital systems adopting those, providers adopting them? Has there been a trend towards that rates of incidence increasing?
Yeah, so there's also, and I say value-based payment, there's also various forms of value-based payment. And so you could just have upside only, you could have upside and downside, you could just have bonus, you could have all these different components. And so right now it's fairly early, and we're really just trying to push people to some upside contracts. So maybe you reserve a little bit of money and then you can bonus it out based on your contract metrics, rather than you not hitting your metrics and then now you're losing money that your business as a, your health, your practice is budgeted for the year. Now you lost that because of not hitting certain measures. So right now we're really just trying to get people's toes in the water with just upside only. There's not a lot, at least what I've worked personally, I haven't seen any downside risk quite yet applied. But the way this would work, and I'm glad you brought this up with the back surgery situation, is you have all these, what I failed to mention about fee for service as well, is when you're so a lot of times when you're in the clinic, doctor just says, hey, let's check this, that, and the other as well, just right? Because they're getting paid for it. Your insurance covers it. You don't care. So you're like, yeah, okay, I want to be healthy. Might as well check out X, Y, and Z, make sure I'm in tip-top shape. But in reality, that cost is not necessary. For no reason did you get these tests done or these extra services or what have you. Whereas in a value-based arrangement, you're really controlling these costs, because in order to have this bonus payment or an upside bonus pool, you need cost savings. And so those bonus pools are driven by those cost savings. And so you begin to have a much more aware provider that's making sure they're not doing things like that when they're not absolutely necessary. And a lot of times with health and just the way that we're brought up, and I don't really blame the individual at all, but you want to be healthy. Like, why would you take a risk? Like, I might as well get the best possible thing, when in reality, you could have just done something far less expensive that probably has the same outcome, but just might not leave you with, the feeling that you got the best care possible. But in reality, it was the appropriate route. It's just, if you're not paying for it, you don't really care. So you just round up to, the Big Mac supersize, because why not, right?
Totally. Yeah. When you mentioned, I think you used the term silos. So when you have fee for service silos of providers, you just run into a classic, every problem is a nail when you're a hammer, right? And so if you're a surgeon and you're cutting open knees and you're doing knee surgeries, every problem, you're not every problem, right? But a lot of times you're going to think that things are going to require surgery. You're going to need to cut someone open, when physical therapy might be a solution there. And so when you don't have some coordinated care, understanding the economics of the care, and most recent research on, different kinds of therapies, alternative therapies, and their relative costs, when that's not a conversation, you don't have an ability to actually reasonably assess for someone what's going to make sense for them.
Yeah, beautiful. Coordinated care, absolutely a huge issue. Within its own department, it's just crazy. But with the hammer and the nail, what if you just bought a new, shiny, expensive nail and now you want to use it, right? Like you just got this new awesome robotic surgical machine, and now it's
Mm-hmm.
like we need to get a return on this machine, right? So now we're going to use this as much as we possibly can. Any problem that could possibly fall into this category, we're gonna jump on it. And so
Right.
it's
Well, a lot of
exactly
medical devices, they come with like calculation models for when you're going to pay off your investment. It's not, here's what it's going to do for patient outcomes. It's, here's what it's going to do for an ROI in your medical practice. Like that's such a
right.
disconnect.
Right. Well, I mean, it's a business, and that's the problem with the way that this system's set up, right? Like it's their businesses, and this is capitalism, and the people
Yeah.
are like that's the cash. It's a crazy way of looking at it, but it is what it is, at least in your typical fee for service environment. And now
Right.
the metaphor I love to use, the most simple one to kind of describe value-based payment versus fee for service, while we just touched on these like crazy awesome machines and like physical things you can buy, we're neglecting improving process, right? So we're focused on improving our stuff instead of the way that we behave and operate, right? And so the
Mm-hmm.
example I like to use is like, and so the term for population health management, a lot of the payment mechanisms go through something called capitation, which
Mm-hmm.
is a fancy word for basically like an allowance. And so I don't know if it was before we were recording or during, but you're talking about risk of assessing people, and someone like us that has no pre-existing conditions, or I'm assuming no pre-existing conditions, we might be worth X amount a month to the health plan. Someone will decide we cost this much to the health plan in order to keep healthy, whereas someone
Right.
else with diabetes and X, Y, and Z might cost a different number to the health plan to keep healthy. And then what you'd end up doing is you would take all of those risk scores, you'd apply that per month per member amount to them, and then that health plan would just get that payment every single month, regardless of what procedures took place. So in a
Mm-hmm.
perfect world, and obviously it's not a perfect world, this would never happen, but if no one got sick or no one had any catastrophic injuries or illnesses, then you as a health plan, you would just pocket that money, distribute it to your providers based on whatever mechanism or funnel that you had agreed to, and then you're sitting at home with your feet on the desk, cashing that check, not doing nothing, because you would spend your days on preventative and checking in with your patients that have a higher propensity for those more costly procedures or diseases or what have you. And
Mm-hmm.
it incentivizes you now, instead of just trying to get as many procedures in a day, like how many people can I see from 10 to 4 in a day, to just how many people can I how can I hire out more social workers or more care navigators or more lower end, I don't say lower end, but more like people based, less highly specified workers can I employ now, and kind of change the framework of my business to something that keeps people healthy, so that we don't end up spending all of this money on procedures, yet the population is still healthy. And that's kind of
Right.
the
Yeah.
end
You're
goal.
prepaying care. Yeah. You're prepaying for the care. You're saying, here's, whatever it is, let's say it's, $4,000 per member per year, manage this population, take care of people.
Right.
Right.
Yeah. Create a nutrition program and go out there and like maybe incentivize people to show up and do whatever you can. Right.
Yeah.
It's the other, and I said the metaphor, I never got to it. It'd be like mowing a lawn, right? You pay someone $20 to mow your lawn, and you pay them $20 a mow, or you just pay them to keep your lawn at an inch tall every single month, right? So if you just
Mhm.
pay someone every mow, they're just going to come as much as they want and mow as many times as they can. Whereas if you say I want it an inch tall, people are inherently lazy or efficient, we'll say, but they'll
Yep.
come up with fun, exciting new ways to keep that lawn an inch tall, maybe without even mowing it ever. Maybe they figure out another way, and it's the mindset behind the approach is just a lot different. And
Yeah.
people initially, they're just so used to getting paid a certain way and they budget a certain way. And it's just, there haven't been a lot of, I guess, wide scale successes outside of Kaiser to really point to, but
Mhm.
there also hasn't been a lot of situations that are set up for it really diving in head first and giving it a go
Totally. Well,
to the
yeah,
degree
like
that
this.
we would like to see.
Totally, yeah. Because Kaiser, like, they're such a unique animal, right? Out here in California, they're huge, and love them or hate them. Some people love them, some people hate them. But that model has proven some pretty good dividends, right? I guess you could look at one example I would pull from like the financial industry, right? So if you've seen Boiler Room or any of those older, financial movies, right? You've got these people who are, selling stocks, they're calling up people trying to sell mutual funds. What was their incentive structure? The incentive was that if I sell you a mutual fund, I'm getting paid 5% immediately on how much money you invest. So Levi, I call you, you got $10,000 to invest in some mutual fund. I'm going to get paid what, 5% off of that? It's $500. That's a pretty good deal, right? I'm going to call a lot of people because if I want someone to buy, I'm going to get $500. And so there's this propensity to then churn deals, right? And you see that with banks and credit cards, right? Again, they try to churn credit cards. They try to get people into more credit cards. But you've now seen a shift in the financial planning world where there's more of a alignment of incentives. So you're seeing financial planners getting paid a percentage of assets under management. What's the incentive there? It's to grow your assets. So if I'm doing stuff that's going to lose you money, I'm losing money. That's money coming out of my paycheck, right? And a further alignment there is going even more to the value-based, is having different incentive contracts with people or getting paid on an hourly basis. Just saying, hey, my time is worth X dollars per hour. I'm going to spend 10 hours, say a year with you doing your financial plan. This is how much you're going to pay me. I got to manage my costs. I got to manage my costs like a business owner because, like you said, there's that upside and downside risk. It's interesting. There's just the incentive structures with healthcare is just all over the board. And I think that's, like you're getting at, a lot of the issues that we run into. I was reading some things. I want to hear what you think about COVID and how that's been affecting some of the conversations you've had with providers. It sounds like with the fee-for-service versus the value-based or capitation model with providers, the capitation payments have actually been keeping a lot of medical practices afloat, right? As a lot of outpatient procedures went to basically nothing for a few months there, and they've slowly been ticking back up. Have you been hearing from providers the impact of COVID on their interest in pursuing value-based or capitation models?
Not in particular. A lot of the projects that are COVID-based have been pretty much financial service related. Like companies, like you said, the outpatient services are going down and they're just looking for guidance on how to, navigate the systems that'll give us, the government programs and all that to get an influx of cash. And then we have a lot of contact tracing. So those are the two that we've been involved with specifically. But as far as just how capitation will work as a whole, I think there's two ways to look at it, because capitation isn't just this, shiny thing that'll fix all the problems. Because something like COVID, right, if it impacts a ton of people and now all of a sudden everyone's really sick, well, your risk score didn't account for that, right? So these one-off events, or if you get stuck, for some reason a large percentage of your population gets, late stage cancer or something like that, right? It's just anomalies in what you budgeted for with your risk scores.
Well, because if I get cancer, that usually doesn't mean you're going to get cancer.
No, right. But I'm just saying, if
it's a totally different model right now.
Yeah, if something happens, exactly, with COVID and all that, but just if something like this happens where a ton of people are sick and now your typical just preventative and maintenance-based health is your costs aren't what you're getting, your per month per member monthly allotment isn't enough to cover what you're dealing with, you're going to end up with a loss there, and it's unfortunate, right? So that is where the risk is involved. But then on the other side of the coin, maybe, we see a lot of these people that are really getting sick with this. A lot of this has to do with, being overweight and having other comorbidities that may be prevented or preventable if you had a more mature value-based system already in place. So on one end, it could really, really hurt you if your population gets hit by it pretty tough. But again, in theory, your population should be strong against it based on the preventative measures that you've put into place up until that point.
Got it.
Yeah, but it's a risk.
Yeah, it's putting a risk on the providers. Have you, for some of the providers that have been in the value-based model longer, if you think about it, right, the nutrition programs, the wellness, the exercise, kind of those low cost but longer term ROI projects, they take a while, obviously, to have an impact, right? Because if you go on a nutrition plan, you're not going from a BMI over 30 all the way down to 24, right? It's going to take time for you to see those results. So are you saying anything with providers where the longer they've been in a value-based capitation model, the more results they're seeing from it? Is there a longer term, buildup that they see essentially?
Yeah, I would answer that with the incentives haven't been as strong as they probably should be, because we are dealing with a lot of upside only. And so just like human nature, they follow the dollars, they do exactly what they need to do, and then they're done, right? Like I check the box and I stop at the box. And so what I think what we need to do, and what we also would love to push, is make the goalpost a little bit further, right? Like those incremental shifts in what we're asking of providers and of these health systems. And so yes, I think it's a longer term buildup, but right now we're just trying to get them a taste of what value-based payments are in these capitation arrangements. And also, like, we're not doing global capitation where we're just giving one big payment. Like, a lot of these arrangements are specific, right? We might carve out things like pharmaceuticals that are just really high cost variables that you don't really feel comfortable with managing quite yet in this current environment, right? And so maybe you only capitate a certain set of services. And so it's really is, crawling before you walk, before you run. And right now, I think it's really in the crawling phase, but we are seeing people looking towards it. Like it has been, it's done well financially for the organizations that I've been involved with so far.
Got it. That's interesting. Another area that we've been talking about a lot more during COVID, because we haven't been able to physically go see a doctor, is telemedicine. Are you seeing any impacts with telemedicine on value-based capitation and provider relationships? What's going on there?
Yes, and COVID's been if there's any positive, it's been great for pushing telemedicine onto the general population. My mom actually just the other day had her first telemedicine phone call, which is fantastic, right? Because that is one of the low cost. It basically serves the same purpose in a lot of different ways, especially when it comes to like people running to the ER and things like that, where you just need someone to say, hey, you know what, you're fine. We can schedule something later. I know you feel a certain way, and you taking your health seriously, and I'm glad that you're making this call and really being on top of your health. But like, this isn't as urgent as you think it is, and this is a more planned, rather than just like freaking out and running to the ER, because that's really where a lot of our wasted costs are. If the population would just stop running to the ER, every time they broke a bone, or like, there's certain things. I'm not saying you shouldn't go if you think you're worried, like absolutely, it's your life, and definitely, you don't want to chance it on certain things. But I think we've been conditioned a little bit to jump the gun when it comes to rushing to the ER, especially, and you mentioned before, a lack of PCPs. You don't even have a primary care physician to set an appointment with on Monday. And so you do just go run. And so it's not just one cause, but I would say that's, the telemedicine, I think, becoming more mainstream is going to be a huge step forward when it comes to reducing costs and just informing the general population of what their options really are.
Right. You mentioned ERs, so that was reminding me, we kind of talk about how fee for service, it essentially creates a credit card for health systems to just ring up for everything that they can possibly find, because it like you said, there's the incentives and people are going to follow the money. And, everyone's familiar, I think, with the term ambulance chaser for an attorney. But if we actually look at the ambulance itself, right, ambulances received a ton of private equity interest in the last 10 years, because they realize there's all this money to make in picking someone up, dropping them off at the ER, finding out that it's out of network, and then going back and billing those people for thousands of dollars that they didn't need to otherwise spend. You even saw private equity groups get into like helicopter medical transport for non-emergency services, but they're flying people 100, 200 miles. They're rigging up like a 6-figure helicopter flight for a non-urgent medical transfer. And sometimes people are aware of that, and sometimes they're not, because their insurance is paying for it. It's like, there's so many ways that these things can get gamed by the players in the market.
Yeah, absolutely. And you're not in the same frame of mind. You're not thinking the same way. And not to say you shouldn't. And like I said, it's tough. It's easy to sit here right now on a Friday afternoon in an air-conditioned apartment and say you should have a more level head when it comes to rushing to doing the most expensive option at the time, right? But and that's where the education, like a lot of this, it's not even necessarily healthcare. I mean, it is in the umbrella of healthcare, but it's just the information, like how the health system works, how nutrition works, how does mental health affect your physical health, like things like that. These are all, and they call it like social determinants of health, like all of these factors that play into how you perceive and how you navigate this environment, and then what diseases you end up being susceptible to.
Right.
None of this is an accident.
Yeah. Are there any specific chronic diseases that you see providers having a lot of success with in a value-based model in treating, if that's like diabetes, overweight? I know a lot of those are really correlated, but
Yeah, a lot of the contracts that we write have to do with diabetes and high blood pressure,
yeah,
substance abuse, things like that. And they are fairly like, as far as the approach we take to them, it's just being involved, right? It's like, hey, you have a high blood pressure medicine. It's a 60-day supply. It's now been 75 days since you've last picked up. Like, is everything okay? Do you need us to bring you something? Like, why hasn't this been refilled yet? Right? Because
right,
just having someone having, a 18-year-old kid just go down a list and call these people that haven't been, or even, go knock on their door, right? And say, hey, what's going on? Can save, because now this person now might have a heart attack and that's going to cost X amount of dollars. And we could have just paid an hourly wage to, someone that wants to be in the healthcare industry at a younger age, or like when they get older as a young age, as a high school kid or something, and go check in and see what the deal is, and then get the pills to the person that needs them. Right. These
right,
are
yeah,
these are very simple steps that have large, not only to someone's health, but because we're talking cost here. So I feel a little kind of like the private equity people you just referenced, but like, their health outcomes will be better and the cost is just zero. I mean, it's going to be what, like 15 an hour for that kid to go knock on the door to prevent
right,
thousands and thousands and thousands of dollars. And a lot of these people, a lot of times, are be uninsured or, on government programs, which is also costing the taxpayer dollars. And it's all of these hidden fees where people are hidden costs where people, like I said, don't really associate a face, or like, it's not really affecting me. But it affects everybody.
right. Yeah. Yeah. I mean, there's so many things there, right? There's people not really understanding their alternative options for treatments and cares. People not understanding the idea of, pennies and pounds, right? You'd rather pay a few pennies now than be, what's the saying? It's penny wise, pound foolish. Deal with it now, pay for the medications now. One thing that we've seen with some groups, when they're paying for the claims themselves, they're in a self-insurance or a self-funding model, they realize, wow, so we've got, 5% of our population, our employee population, has diabetes. How many of them are compliant with their diabetes management? And of those who are non-compliant, is it just hey, this month I couldn't afford my insulin? Well, that's going to balloon, that's going to mushroom into this gigantic issue. So maybe as the payer, the end payer, right? Maybe we should just be paying for those employees' insulin.
Right.
That's
And
a
that would
realistic
be
thing to do.
if you were in a capitated environment and you were seeing this happen time and time again, you would have an actuary come up to you and be like, hey, instead of doing this, we could just pay for like, it would be a thing, right? Like, I doubt Jeff Bezos and his health plan, he would let his diabetic people miss their appointments for checkups, right? Like, if you're managing the population and you're closely in tune with every step of the process, you would see these simple things getting neglected and their impact later on. And you would make
Mhm.
sure that it would stop. Like, you would put a plan in action to remedy that. Absolutely. And it's
Right.
that
So
there's just no one leading the charge, because people are just getting paid right now.
it's fragmented. It's so fragmented. And one example of that fragmentation, I'm sure that comes up in the value model that you're talking about, is data, right? And so in the fee for service, no one's using the same model for data. So it's really hard to communicate from silo to silo, right? Whether you're going to see your GP, who's then sending you to a specialist, who's then sending you to go get tests, that stuff, there's no communication going on there, right? Sometimes if they're in the same health system, there's a bit going on, but again, it's still fragmented then on a national level. And so, you see that someone moves, say, from like Connecticut to California, they've got to bring their medical files with them in some way. There's no way for this to be there's no one database. So for the value-based models, for them, when they're trying to communicate these things on data, a lot of data, right, is really, again, it's following the money. The data is available for billing purposes. It's not really for treatment purposes. What are you seeing providers do with regards to using data for actual treatment purposes and not just for billing?
Yeah, good point. I mean, personally, I haven't seen anything really about that. Like, and to your point with the fragmentation, not only is it fragmented, but it's also oftentimes delayed. So somebody like me, who it is my job to go and look at these codes and see trends, I'm looking at data from 9 months ago for today's decisions, which
What
it's
are you going
just
to do with that?
it's nothing, right? I mean, it's a little bit, but yeah, there's no way to make a decision today to affect tomorrow whenever you're flying blind, right? So much can change in 9 months. And not only that, like with current private situations where, you know, your plan changes or, you know, provider jumps ship to one or another, and now it's not simple to transfer this data. There's been times with health, like we'll have I've heard of health plans in Texas actually had a computer locked in a room, but didn't have access to any other systems, like no internet or anything, and those files are just stuck there. And so if you ever wanted anything from that, you'd have to go to that computer and literally print it out and like there's no way to transfer the information. Also, there's some HIPAA compliance issues with that as well, where the reasons why it was set up that way. But the times have changed, and a lot of the policy and governance around it hasn't really grown with the times, which I'm all for patient confidentiality and all of that, like of course. But we live in a data world, and healthcare hasn't really, you know, grown with the times in that regard.
Right. I mean, the fact that HIPAA has not been updated really, and the fact that faxing is still one of the only allowable ways for records to get transferred is crazy. You know, like we deal with that if we're doing certain kinds of planning for people and they need their records, we get them faxed by providers to us, right? They don't have some kind of over the internet data transmission. Now, you know, a lot of people have different ways of faxing through email, but it's still like, that just, I think, goes to show you the difference, because no one has a fax machine anymore. It's all digital fax, e-faxing. It's a complete disconnect with how people actually operate today and things going on for them. Oh.
And again, with the financial incentives with the data, sorry to one more, you also have people have this data and they're not going to give it to anybody. They want to sell it, right? Like when it's for the greater good. And I get it. It's a business and you probably paid money to mine it or however you obtain this database. But a lot of what we have is, you know, people have subscriptions, they're very expensive subscriptions to these environments to get just generalized data. I mean, it's helpful, but again, like it's fragmented, it's super delayed. And it just doesn't make sense. Like if you're trying to run your own health plan, and that's why you see a lot of these companies just having their own health plans, because you can keep everything in-house, right? And again, that's why Kaiser's been so successful. And it's why we see a lot of larger corporations just saying like, hey, why are we paying someone else through the nose to do this whenever we have all of the infrastructure here to do it ourselves?
Right. Or you can outsource it to people and build a team who can do it, right? Like that's the thing we always are talking to companies about, is like you can pay just one insurance carrier, for example, to do something, but you're playing a game where heads they win, tails you lose. You're going to lose either way, right? And so you have a good year, well, that's great. The insurance company, that's just earnings for them. You have a bad year, well, the carrier's going to come back, charge you more than next year. So you're paying for all this stuff at the end of the day. There's no insurance going on there. So you might as well take more control of it and understand what's going on. You got to know what's going on. You got to see the data. You got to understand where people are getting care, how they're getting it. Are there, you know, before we go today, are there any other topics you wanted to touch on? I know we kind of pounded capitation, value-based payment, population health management. Is there anything else you wanted to touch on before we go?
Nothing in particular, but just kind of want to reiterate like personal accountability too, right? Like with anything in life, you're the only one that can really, you know, you're in charge of you. It's never going to be someone else's fault. You can only place, I mean, I'm not a big fan of blame anyways, but like just know what's going on with yourself as well. Like take personal accountability. And that goes with, you know, finding your insurance plans or your own personal health or whatever it might be. A lot of this, I think it's the culture of healthcare has been no one is taking the accountability. It's kind of just people eating off the next guy down the line. And especially when it comes to the dollars, right? And
Totally.
Hopefully just the culture can shift a little bit to really caring about the people and just the knowledge. Because like if someone's out there, like there are countless people out there trying to spread news on nutrition and health and fitness and all of these things, mental health, you name it. A lot of times falling on deaf ears, right? So just as a community in general, like be an active participant in what these people are really trying to do, because we can write any contract we want and write these incentive plans and write these value-based contracts. But if, you know, people are just doing it to check the box and then they're done, like we're not really, you know, getting anywhere. I mean, we're getting
people
somewhere.
People do usually
obviously
engage with health. Yeah. It's
it's
always reactive.
Something people don't like to think about, right? It's just that no one likes to think about their own mortality and all of that. But like we are all going to die. Hopefully we do so gracefully, right? And so,
right. And then hopefully along the way we're doing some good for other people, and that's, I guess, bringing a full circle what we're doing here, trying to talk about solving a $3.6 trillion industry. Is that the latest figure on healthcare?
And we're the sickest, the sickest. It's crazy.
Yeah, we're paying so much and we're getting so little.
It's terrible. And that's, yeah, it's the whole thing too. It's more than just healthcare. It's a seismic shift in general, like of caring about people. Like we've proven we don't care about people. And
Mhm.
it's just not a way to live. You got to care about people. It's literally all we have is each other.
Yeah. Yeah. We got to pick people up. We got to reach hands out. We got to lift other people up and then be willing to put people on our shoulders. Right. So, yeah. Well, Levi, thanks for joining us today. What is the best way for people to get in touch with you or to follow you or be in touch in any way? Is it LinkedIn, Twitter? What's up?
Yeah, LinkedIn is probably good. Twitter at Levi Remmick. That's probably about it. If you want to check out Copel Solutions, copelsolutions.com. We work all varieties of healthcare, network development, all that fun stuff.
Got it. Cool. All right. Well, thanks everyone. Let us know if you have any questions and we'll let you go. Have a great weekend. Talk to you soon.
Awesome. Great to catch up. See you later, John.
Yeah. See ya. Bye.
Bye.